You know that incredibly pervasive cultural trope,
Yeah.
right? The almost universally accepted joke among mothers that once you have a baby, your days of jumping on a trampoline are just officially over.
Oh, absolutely. Yeah, the whole I laughed so hard I peed a little thing. I mean, you see it printed on greeting cards. You see it used as this like reliable throwaway punchline in basically every movie about motherhood.
Right. But, if you strip away the humor and, quite frankly, the stigma, what we're actually looking at is stress urinary incontinence or SUI.
Exactly.
It's this very physical reality of leaking urine when there's sudden abdominal pressure.
Yeah.
And culturally, we've just sort of decided to treat this as an unavoidable, slightly embarrassing rite of passage.
Yeah, like it's just a normal inconvenience.
Right. But when you actually dive into the medical research that we have today, I mean, the neurophysiology, these crazy 3D computer simulations, the clinical studies, you quickly realize this isn't just some inevitable, loosening of the body.
Mhm.
We are looking at a highly specific neurological injury.
Yeah, brushing it off completely ignores the underlying biology of what a human body is actually enduring. I mean, we're talking about a profound mechanical event that dictates long-term neurological health.
Which is wild.
It is. And to really grasp it, we have to look past those surface symptoms and dig into the cellular anatomy.
Which brings us to the core mission of this deep dive. Whether you're a medical professional, a parent, or just, fiercely curious about human anatomy, this is going to completely change how you view pelvic floor health.
Oh.
Because we're asking one very specific question today.
Right. Can a physical stretch injury to the pudendal nerve during a prolonged labor actually be the root cause of persistent, long-term neurogenic stress incontinence?
Okay, so to figure out how one single nerve could cause decades of leaks, we probably need to know, well, where this thing even is, and why childbirth puts it directly in the line of fire.
Yeah, so to map this out, try to imagine the geography of the human pelvis. The pudendal nerve, it originates at the very base of your spine, specifically plugging into the S2 to S4 segments, of the lower spinal cord.
Okay, lower spine. Got it.
Right. And from that starting point, it has to navigate this crowded, incredibly complex anatomical landscape. So it snakes its way deep through the pelvis, passing through a narrow, bony passageway called Alcock's Canal.
Alcock's Canal, right.
And eventually it branches out to supply vital electrical signals to a few really crucial areas. So the external urethral sphincter, the anal sphincter, and the levator ani, which is essentially the main muscle group making up your pelvic floor.
So it's basically the primary communication cable keeping the whole lower pelvic system supported and, closed.
That's its main job, yes. But the anatomical quirk that makes the pudendal nerve so uniquely vulnerable is that it isn't just floating freely in the tissue.
Right.
It's actually physically anchored in place at this sharp, bony landmark in the pelvis called the ischial spine.
Okay, so if you're listening and trying to picture this, imagine a short, thick electrical cord plugged into a wall outlet. The wall outlet is the spine, right? And the appliance it's powering is the pelvic floor.
That's a great way to look at it.
So if you take that appliance and you push it way too far away from the wall, the cord can't slide to give you more slack because it's anchored.
Exactly.
It just stretches caught.
Yeah.
And if you keep pushing the appliance, eventually that cord is going to start to fray.
Yes. And during the second stage of labor, the active push-in phase, that appliance is absolutely being shoved away from the wall.
Right.
As the fetal head descends through the birth canal, it introduces just massive mechanical stress. The tissues of the entire pelvic floor are stretched downward and outward and aggressively compressed against the bones of the mother's pelvis.
And the numbers in the research on this specific compression are honestly staggering. I mean, we're talking about localized pressure applied to the vaginal sidewall, reaching up to 240 centimeters of water during peak contractions.
Which is an immense amount of physical force.
Yeah.
And, that force doesn't just pull the nerve like a rubber band. When tissue is squeezed that tightly between a descending fetal head and the pelvic bone, you trigger a state called microcirculatory ischemia.
Microcirculatory ischemia. Okay, break that down.
Basically, nerves aren't just solid wires. They are living tissue woven with these microscopic blood vessels that supply them with oxygen and nutrients.
Oh, wow.
So when that 240 centimeters of water pressure hits, those tiny capillaries are completely pinched off. So the nerve is simultaneously being stretched to its physical limit, and it's suffocating from a lack of blood.
Okay, hold on. I want to challenge this narrative for just a second, because if you ask most people honestly, if you ask a lot of general practitioners, they'll tell you that postpartum incontinence is just a structural muscle issue.
Oh, all the time. Yeah.
Like a large baby physically tears the pelvic floor muscles on the way out, the muscle is ruined, and that's why someone leaks. So why are we dragging this, like, suffocating nerve into the picture?
Well, assuming this is a purely muscular issue is probably the single most common misconception in postpartum care. To see why the nerve is actually the main culprit, you have to understand a concept called the hammock hypothesis.
Okay, the hammock hypothesis. Let's get into that.
Yeah, so it's the mechanical explanation of how continence actually works when your body is under stress. Your urethra, the tube that carries urine, doesn't just pinch itself shut in empty space. It relies on a firm backboard for support.
Like a literal backboard.
Right. And that backboard is constructed from the endopelvic fascia and the anterior vaginal wall, and that whole structure is suspended by the pelvic floor muscles. It functions exactly like a taut hammock.
Okay.
So when you cough or jump or sneeze, your internal abdominal pressure suddenly spikes. That pressure pushes downward on the urethra, but because the hammock is firm, the urethra gets tightly compressed against it and essentially sealed shut.
Ah, I see. So it's like if you step on a garden hose that's lying on a concrete driveway, the water stops because the concrete is a firm backboard.
Exactly.
But if you put that same garden hose on a trampoline and step on it, the trampoline just sags, right?
Yeah.
The hose doesn't get crimped, and the water just keeps flowing.
That is exactly what happens. And what keeps that bodily backboard firm, what keeps it acting like concrete instead of a sagging trampoline, is muscle tone. Okay. But muscles don't just magically stay toned on their own. They require a constant, subtle stream of electrical signals from the nervous system to maintain their tension and structural integrity.
And those vital electrical signals are coming straight down the pudendal nerve.
Yes. Which brings us back to the delivery room. If that pudendal nerve is damaged by being stretched and starved of blood, it stops sending those baseline signals to the levator antimuscles.
Wow.
And without that constant neurological instruction to flex and hold tension, the muscles literally don't know what to do, so they begin to weaken and atrophy.
So the electrical cord is frayed, and the appliance just shuts down. I mean, even if the muscle itself wasn't directly torn by the baby, it loses its power source.
Precisely. And when those muscles atrophy, the hammock sags. It completely loses its structural integrity.
Right.
So the next time abdominal pressure pushes down on the urethra during a sneeze, there's no firm backboard to compress against. The urethra fails to close fully and urine leaks out.
That makes so much sense.
Yeah. In the medical literature, this is called a dual pathology. You might have some direct mechanical tearing to the muscle fibers, sure, but you also have this silent denervation.
Which is the loss of the nerve signal.
Right. The total loss of the nerve signal that prevents the muscle from functioning or, even healing properly.
But this raises a really obvious contradiction to me. Almost every single vaginal delivery involves some degree of stretching and pressure. I mean, the baby has to come out.
Of course.
Yet we know plenty of women recover their pelvic floor function entirely within, like, a matter of weeks, while others are dealing with leaks for the rest of their lives. So where's the actual line? When does a temporary nerve stretch cross over into a permanent, lifelong injury?
Well, finding that exact line is where those 3D computer simulations come into play. Researchers couldn't just guess, obviously, so they built these intricate geometric computer models of the female pelvis to simulate the descent of the fetal head. And they used these models to calculate exactly how much the nerves in the pelvic floor stretch. And they discovered a very specific breaking point. It's known as the 15% strain threshold.
Just a 15% stretch? That doesn't sound like a lot.
It's not. But the simulation showed that if appendicular nerves, which are the nerves that branch out to service your limbs and lower body, like the pudendal nerve, if they are stretched beyond 15% of their original resting length, the internal architecture of the nerve fibers snaps.
Oh, wow. So it actually breaks inside.
Yes. It's no longer just a temporary loss of blood flow. It becomes permanent structural damage. The nerve has crossed the point of no return.
Okay, so the obvious next question is, what pushes a delivery past that 15% threshold?
The clinical data points to a few very clear obstetric risk factors. The most significant one is a prolonged second stage of labor.
The pushing phase.
Right. If a mother is in the active pushing phase for more than 1 hour, the risk of significant permanent denervation injury spikes dramatically.
Over an hour. Got it.
Yeah. And other major factors include macrosomia, which is having a baby with a very high birth weight, and the use of forceps, which can introduce, rapid, unnatural alterations to the geometry of the stretch.
And if you're listening to this and wondering how a pushing phase even lasts that long, there's a really fascinating, somewhat counterintuitive nuance in the data regarding epidural anesthesia.
Yeah, this is a big one.
Because epidurals are an incredible tool for managing extreme pain, right?
Yeah.
But a well-known side effect is that they can significantly prolong that second stage of labor.
They can.
For a woman having her very first baby, medical guidelines sometimes allow for the second stage to be observed for up to 4 hours if an epidural is working well, to prioritize avoiding emergency surgery.
It's a constant balancing act in obstetrics. I mean, the epidural keeps the mother comfortable, it relaxes the pelvic floor, and it often avoids surgical intervention, which are all vital priorities. But if we look at this purely from the perspective of the pudendal nerve, that is, up to 4 hours of a fetal head wedged deep in the pelvis, compressing the tissues against the bone, starving the nerve of its microcirculation, and holding it in an extreme stretch.
It's just sitting there under pressure.
Exactly. Extending the pushing phase inadvertently raises the probability of blowing past that 15% structural threshold, which results in permanent nerve damage and postpartum urinary retention.
So we have a really clear picture of how the injury physically happens in humans. But to figure out if and how the body tries to fix this dual muscle-nerve trauma, researchers couldn't just repeatedly subject women to controlled pelvic trauma to see what happens on a cellular level.
No, ethically, that's not going to happen.
Right, which is why the science heavily pivots to animal models here.
Yeah.
Specifically rats and mice.
Yeah, bringing this down to a laboratory setting with rodents allows researchers to really isolate the variables. So, to simulate childbirth injuries, they rely on two primary techniques: pudendal nerve transection, known as PNT, and vaginal distension, or VD.
Okay, so transection is exactly what it sounds like. They just surgically cut the nerve to see what happens when the muscle loses its signal entirely.
Right.
But vaginal distension is the one that really mirrors human childbirth, right?
It is.
The researchers essentially inflate a small balloon inside the vaginal canal of the mouse to safely and accurately replicate the mechanical stretch and compression of the descending fetal head.
And the results from the VD studies are remarkably consistent with what we observe in human obstetrics. Inflating that balloon creates a reversible state of stress urinary incontinence.
Okay.
But crucially, when they analyzed the tissues, it confirmed the dual pathology we discussed earlier. The researchers saw distinct measurable damage to both the muscle, so the external urethral sphincter, and the neurofilaments that make up the pudendal nerve.
But the way the mouse's body responds to that dual injury is where the biology feels almost like science fiction to me.
Oh, it's incredible.
Because the muscle and the nerve don't just heal in their own isolated bubbles. They actually talk to each other.
They actively communicate. As the injured muscle fibers begin to repair themselves, they secrete these highly specific chemical messengers known as neurotrophins.
Neurotrophins.
Yes. And the most prominent ones in this process are nerve growth factor, or NGF, and brain-derived neurotrophic factor, BDNF.
Okay, NGF and BDNF.
Right. These neurotrophins act like biological homing beacons. The healing muscle releases them into the surrounding tissue to signal the damaged pudendal nerve, essentially coaxing the frayed nerve endings to regenerate and grow back toward the muscle.
That is just wild. It's like trying to rebuild a coastal city after a massive hurricane, right?
Yeah.
You can't just fix the electrical grid if all the office buildings and houses are destroyed.
Exactly.
And conversely, rebuilding the houses is useless if there's no power line running to them. They have to be rebuilt in tandem. So the buildings, the muscles, literally have to send out a distress signal requesting the power grid to reconnect to them.
That's a perfect analogy. And in this storm-damaged city scenario, the rebuilding doesn't happen overnight. For these mice, the studies show it takes about 20 solid days post-injury for the urethra to be successfully re-innervated by the pudendal nerve, and for their leak point pressure, which is the metric researchers use for continence, to fully bounce back to normal.
Okay, so 20 days for a mouse to rebuild its pelvic floor. But this brings us to a massive, glaring contradiction in the human data.
Here we go.
If animal models clearly demonstrate that the continence mechanism has the biological tools to regenerate, why do human epidemiological studies show that incontinence rates actually rise dramatically years, sometimes a full decade after childbirth?
Yeah, that's the million-dollar question, right? And it comes down to a phenomenon we can call the illusion of recovery.
The illusion of recovery, okay.
Yeah. When electrophysiological studies are conducted on women shortly after a vaginal delivery, the numbers are sobering. About 42% of them show clear, measurable evidence of neuropathic injury to the pelvic floor.
Wait, 42%?
Yes.
Nearly half of all vaginal deliveries result in verifiable nerve damage.
That's what the data shows. Now, check back in 2 months later. The data shows that 60% of those injured women will recover their pudendal nerve function.
Okay, so that's good.
It is. The nerve heals, the communication is restored, and they regain continence. But the critical caveat to that statistic is that the recovery is almost always incomplete.
Incomplete how?
Well, the nerve regrows, but it might lack the same density of functional fibers. Or the muscle repairs, but it might be slightly weaker or, interrupted by scar tissue.
Oh, I see. So the city is rebuilt, the lights are on, but the power grid is fragile. It's functioning at maybe 80% capacity instead of 100%.
Exactly. And this explains the 10-year gap. A woman might go for years feeling completely fine, entirely asymptomatic. She doesn't leak when she sneezes. She can jump on the trampoline.
Right?
And that's because the human body is an absolute master of compensation. If one specific sphincter is weakened or the levator ani is partially denervated, other surrounding muscles and connective tissues in the pelvic floor simply work overtime to pick up the slack. They mask the injury.
They compensate.
Yeah.
But then we get older.
Right. As we transition into our late 30s, 40s, and beyond, natural physiological shifts take hold.
Right. Things change.
Yeah, we experience a general baseline decline in muscle mass. Our connective tissues lose a bit of their elasticity. And crucially, our overall peripheral nerve density naturally decreases.
So the surrounding muscles that were acting as backup generators, they start to fail.
The compensatory mechanisms that successfully hid that initial childbirth injury for a decade, they finally wear out. The physical toll becomes too much, the backup systems shut down, and suddenly that persistent neurogenic stress incontinence reveals itself.
Wow.
The structural damage happened in a delivery room at age 28, but the physical symptom doesn't manifest until age 40.
Which completely reframes the entire timeline of postpartum recovery. I mean, it's not a 6-week process. It's a decades-long game.
It really is.
But, if you're listening to this and thinking, well, I'll just get a C-section to avoid stretching this nerve in the first place, the data actually has a massive, highly specific caveat for you, right? I mean, does a C-section actually act as a magic shield against pelvic floor damage?
The research forces us to make a very sharp distinction here between an elective C-section and an emergency C-section.
Okay, what's the difference in terms of the nerve?
Well, an elective C-section, which is scheduled and performed before the onset of labor, before the baby ever drops into the pelvis, that does seem to protect against the specific pudendal nerve stretch injury.
Makes sense.
Yeah, the electrophysiological studies show virtually no evidence of this denervation in women who deliver exclusively via elective C-sections.
Okay, but what if you labor for hours and then end up needing an emergency C-section?
That's the caveat. If the surgery is called after late-stage labor has already begun, say a woman labors until she reaches 8 or 9 centimeters of dilation, the fetal head has already descended. It has already wedged deep into the pelvis and physically compressed that pudendal nerve against the ischial spine for hours.
Ah, so the electrical cord has already been pulled past the breaking point. Pulling the baby back up and out through an incision doesn't just undo the strain that already happened.
Exactly. And the clinical data backs that up perfectly. Researchers measured the pudendal nerve terminal motor latency in these patients, which is essentially a test of how fast the electrical signal can travel down the nerve.
Okay.
They found that women who underwent late-stage C-sections exhibited the exact same prolonged latencies and permanent nerve damage as women who delivered vaginally, because the primary damage isn't caused by the final 30 seconds of birth, It's caused by the hours of heavy compression leading up to it.
Right. Let's synthesize all of this because it is a lot of dense biomechanics to wrap our heads around. We started by asking if a pudendal nerve stretch injury during prolonged labor can cause persistent neurogenic stress incontinence.
And looking at the 3D models, the rodent studies, and the human electrophysiology, the answer is a resounding yes.
Right. If that nerve is stretched past that 15% structural threshold, if it's starved of blood for hours during the pushing phase, you end up with a dual trauma. The pelvic muscle tears, its power cord frays, and the structural hammock supporting your urethra just sags.
Yeah.
And because the human body is brilliant at compensating, that specific injury can look completely silently in the background for a decade before the natural aging process strips away the compensation and the leaking finally begins.
It forces a complete paradigm shift in how we view maternal health. Understanding the cellular mechanics here takes postpartum incontinence out of the realm of, things you just have to put up with, and correctly identifies it as a highly specific diagnosable neurological injury.
And the reason this matters to you, whether you're planning a family, supporting a partner, or just, fascinated by the human machine,
Mhm.
is because identifying something as a mechanical nerve injury means it's treatable.
Absolutely.
It elevates the absolute necessity of proper medical rehabilitation. I mean, we aren't just talking about telling women to do a few random Kegel exercises while they're stopped at a red light.
No, not at all.
We're talking about targeted, medically supervised pelvic floor physical therapy designed to deliberately stimulate the release of those neurotrophins we talked about, to actively coax those damaged nerves to regenerate and to consciously rebuild the structural hammock before the compensation fails.
Which leads to a really profound implication for the future of how we handle maternal health care.
Yeah.
Currently, our standard of care involves routinely screening every pregnant woman for things like gestational diabetes, preeclampsia, and hypertension. We consider those preventative screenings absolutely non-negotiable.
Because catching them early prevents catastrophic damage down the line.
Right. But given what we now definitively know about the hidden epidemic of pudendal neuropathy, the fact that 42% of women experience it, and that immediate targeted rehabilitation can actually prompt the muscle and the nerve to regenerate together, what if our baseline standard of postpartum care included routine electrophysiological screening of the pelvic floor?
You mean like running a test on those nerve signals at the hospital or at the standard 6-week postpartum checkup before the woman even knows there's a problem?
Exactly. If we could map the nerve damage in real time, long before the compensatory muscles fail a decade later, we could prescribe immediate targeted physical therapy. We could rebuild the power grid while the city is still actively repairing the buildings, rather than waiting 10 years for the lights to go out.
Wow. If we actually implemented that level of preventative neurological care,
Yeah.
could we eradicate persistent postpartum incontinence entirely?
It's a question the medical community has the data to answer, if they choose to seriously consider it.
That is something to seriously think about, because the next time you hear someone make a joke about leaking when they sneeze or, avoiding a trampoline, you'll know that the punchline isn't just an inevitable fact of life. It's a fraying electrical cord, just waiting to be plugged back in.